one of the reasons we're somewhat belaboring T-wave inversion this morning, and we'll talk even more about it, is because I think it is the area that in some ways is sort of confusing. If you look at just the anterior precordial leads, in some instances they're normal, in some instances they might be abnormal, and where do we draw those lines? And I think it's super important. And one of the things that came up in our summit discussion this time around was looking at this juvenile T-wave inversion pattern, because if you think about it, what happens if we call these abnormal in that younger age group? What are we really looking for? If you have T-wave inversion without ST segment elevation in a 14 or 15-year-old with no symptoms, and that's isolated to V1 through V3, what are we looking for if we start a workup? Are we looking for HCM in that instance? Probably not. If anything, we might be looking for very early ARVC or arrhythmogenic cardiomyopathy, where the workup is massive. And as Mike Ackerman would say, you pull that lever arm for that workup and you're down a really sort of deep road in investigation. And so I'm really pleased that the evidence is strong that in asymptomatic individuals of any race, and you see that anterior T-wave inversion confined to V1 through V3 and no symptoms, that we can consider that a normal pattern in our younger athletes. So it's been very helpful.
Thank you all. My name is Celeste. I'm a local pediatrician and sports provider. I think I might ask two questions that may be setting me up for more questions throughout the rest of our time together, and I think maybe directed towards Dr. Sharma. If you had to guess, this might be a naive question, if you had to guess what percentage of general cardiologists understand that there are racial differences in ECG reading, what would you say?
The truth is I wouldn't know the answer to it, but we've known about racial differences in ECG, certainly in this broad category of white versus black. Since the early 50s, there are papers showing that black individuals do get a higher prevalence of repolarization changes. But I think this black-white difference has really been highlighted over the past 8 or 9 years. Large cohorts of athletes have been confirmed. So I think some would know. I'm not sure whether they'd know what the specific differences are. If that's the best I can answer your question at the moment.
Okay, and then maybe a follow-up question, also in regards to something that Dr. Harmon talked about in your numerator and your denominator, and in the U.S. and across the world, as we have more of a melting pot. What is the definition of black athlete or black person?
Very good point. And this is one of the Achilles heels of all of what we're talking about is, who determines the genetic pool? Is it self-reported? I mean, most of our studies, it's what someone reports themselves to be. Is it what color someone is? And can color really determine gene pool? And that's the point I was trying to make, that if we look at the prevalence of T-wave inversion in African American blacks, it seems to be lower, considerably lower than in the European blacks. Now, I don't know whether that's because they came from a different geographical area when they came to the Western world or not. And of course, the other thing that is beginning to worry me a lot is the mixed race athlete. Gone are the days where you had black or white. So many of our athletes have one black parent and one white parent. And the question is, how are we going to interpret all this in the future? So there is a can of worms that's being opened at the moment, and we're going to have to deal with that at some stage.
Thank you.
I guess I would just add to we've known that African Americans have higher voltages than Caucasians in pediatrics for a really long time, but we didn't actually have those reference values to support that. So there's a subtle difference between do you know there are differences, and how do you apply what's available to that? And so hopefully the new PHN values will help us distinguish that.
If I could just comment also one thing on the sort of the black repolarization variant. It was actually in our first Seattle summit that Domenico Corrado leaned over to me and whispered, "Look, John, if it goes up first after the QRS complex, before the T-wave, it's normal." And recently there's at least one study from Domenico and his group, I believe, that looked at both black and white athletes with significant investigations in individuals with anterior T-wave inversion that was preceded by the ST segment elevation and domed or convex ST segment, before the T-wave that looks like the black repolarization variant, but in a white individual, and they were not finding pathology. And so it's something that needs to be reproduced. We need more study, and certainly in the U.S., since our numbers of that black repolarization variant are about 1/5 what they find on the continent of Africa. There's some genetic dilution, et cetera. We have a ton of mixed race athletes in the U.S. It's really important that we answer that question, but it could be that what we're really going to do in the end is broaden who this applies to in terms of being a normal repolarization variant in an athlete. Mike?
Another great session. This is for you mostly, Sanjay, but I'm curious, Jack, what you and Joe would do as well. Anecdotes isn't evidence, but it's often the anecdote that really gets you thinking, and the anecdote that you shared, Sanjay, was the pathologic T-wave inversion athlete who dies in the setting of a structurally normal heart. So that athlete who had clearly abnormal T-wave inversion in V4, V5, V6, none of us would like those T-waves. We work them up, echoes normal, MRIs normal. I still have been following those athletes who've chosen to stay an athlete. I equip them with an AED strategy with the team trainer and so forth. And I'm just wondering, in retrospect, in that athlete, was there any clue that the heart was structurally not right, or was it really a sentinel event of sudden death with pristine imaging, pristine autopsy, pristine stress tests, where the only thing was an ugly V4, V5, V6? Anything that you learned about that athlete after the fact?
Well, I'm pleased to say that I wasn't responsible for that athlete, because there was a massive lawsuit afterwards that cost millions, absolute millions, and the club was sued, and the doctors were sued the most, more than the clubs. The clubs washed their hands off it, said it was the doctor's responsibility, and this is because the guy lived, and his parents sued. But clearly, the retrospectoscope is a great tool, isn't it? That you go back and you look at someone's MRI scan and you see that the apex was slightly more thick than the person had appreciated, and also the LV volume to mass ratio wasn't that high. Suggesting that it may have been pathological left ventricular hypertrophy.
So you could make the case that individual with a different phenotype would have said not only is that pathologic T-wave inversion, but it's MRI evidence for apical hypertrophy, which that kind of an ECG would have pointed to in the first place.
Possibly, and I think had that guy not had an aborted sudden cardiac death, you'd have looked at it and said, hold on a minute, it would be tough to call this apical hypertrophic cardiomyopathy. So it's one of those things, and what I was trying to get at was that sometimes you see infralateral T-wave inversion in a black individual and you think, we've not found anything, let them carry on. That's fine, and I agree with that. But I think we don't know enough about infralateral T-wave inversion in this group. Mm-hmm. I actually feel, and this may be a brave thing to say now, that the black athlete has the potential of developing an arrhythmogenic substrate. We all say LVH is bad, okay? If you see LVH in hypertrophic cardiomyopathy, aortic stenosis, hypertensive heart disease, it's bad, it's bad. And I believe that black athletes have the potential of developing pathological LVH with sport. And we're seeing more and more of this. When we look at our infralateral T-wave inversion in black athletes, we're not actually seeing structural evidence of hypertrophic cardiomyopathy, but we're seeing very high relative wall thickness measurements where you've got concentric remodeling and concentric hypertrophy. And I think that is not good. That's my personal feeling.
Well, I think you're right. I don't think that's such a stretch or being radical the same way we would say a white serious endurance athlete has the potential to drive themselves towards a form Frust ARVC heart. So that combination of whiteness and endurance can get you towards ARVC. Blackness and those sports of choice could drive you towards LVH. What are you guys doing practically when you find a pathologic V4, V5, V6? Are you now starting to image them more frequently than yearly? What's kind of your drill that you would be doing?
Without using the word compromise, because I got told off by JAMA Cardiology for using it, I do feel that black athletes are compromised by us, and that we find that every time we go to a sports club, the black athletes start saying, why is it just us that you guys want MRIs on? What about the other white guys that you just said fine to compete? And it takes me a long time to explain to them that we don't understand what T-wave inversion actually means in these individuals. So our black athletes have annual MRI scans if they've got lateral T-wave inversion. I just don't want to take the chances, and a lot of these are very high-profile individuals. We've also done gene testing. We've started doing gene testing in these people. And before, it's still a research tool, but we're finding that the diagnostic yield for infralateral T-wave inversion for a gene that's capable of causing a cardiomyopathy is around 10% in black athletes. It's not low.
If I could just add to that, I think there are three factors that come into play. First is this binary decision of you're okay to play or you're not okay to play. I think these young athletes with these suspicious ECGs need to be followed, and actually it was Mike Ackerman who I think sort of led us into this new era of informed consent when dealing with athletes who have cardiac issues or suspected cardiac issues. And so it's important to have a conversation with them that we think you're okay and it's okay to participate in sports, but you may be taking some risk and you need to have continued follow-up. I see them every year and encourage them that if they have any symptoms that they should come and see us. But I think that one of the concerns I see is that someone has an abnormal ECG, they're seen by someone, and it's pronounced that they either can participate in sports and have no follow-up, or they tell them that they can't, and then they're left with an incomplete diagnosis and not being able to participate in their sport.
Hi, my name is Shannon Woods. I'm from Springfield, Missouri. I had a question about the difference in roles of pediatric cardiologists versus the adult cardiologist, and is there any difference in perspective from the two groups in terms of the question of pre-participation screening EKGs between the two groups?
I think that the challenge in pediatrics, and it's laid out in the Seattle criteria and its updates, is when you're less than 12, the norms are so different that it's hard to apply a simple standard. And so when you get to 12, 14, it becomes more easy, and then above 16, it's pretty practical to apply those. So I'm not sure that the approach is different, but the perspective, as you said, is different because of the variability that occurs. You just can't pick a value that, and apply it to a 10-year-old and say you're normal or abnormal, and that same value applied to a 9, 8, and 7-year-old. So I think we're in alignment with the utility of it, but I think we also caution against just applying it to anybody less than 16. Maybe 14 would be acceptable, but younger than that, no.
Yeah. And I would add to that regardless of your background, whether you're pediatric or adult cardiology, electrophysiology, cardiomyopathy expert, family medicine, emergency medicine, et cetera, if we can all look through the same lens when we're looking at that patient population of an athlete in that age group where we think these criteria standards apply, I think it is most useful in the discussion when you speak with your consultant to make sure you're looking at, through the same lens, the same scope, using the same standards.
Hi, I'm Diane Breck.
Just
Sorry.
in our community, it's about evenly split between the adult cardiologists and the pediatric cardiologists as to who is in favor of and who's opposed to screening. And over the last 10 years, there's been this gradual evolution where it's accepted by more and more of them. So I think it's more dependent on not whether they're pediatric cardiologists or adult cardiologists, but whether they have a particular interest in this segment of cardiology.
Hello, I'm Diane Breckenridge. I am from the University of Pennsylvania, University of Maryland, where my nursing research and healthcare research and a lot of agency research with the government has been done. I am now in Phoenix with the Anthony Bates Foundation. I would like to return back to the race discussion because of the person that brought up with the sports editor situation. I know the race we're speaking about here is white and black, so we'll just keep it at that at this point. So when we do any government grants now, we have to have it whereby we also have the ethnicity piece of Hispanic and non-Hispanic. And I was not sure. I've been reading rapidly because I've done cardiology in the past, but I've been reading rapidly all of the work. And I think within the United States, it'll be interesting to see if that piece will also come forth. What are you seeing yourself with that? and the Hispanic or non-Hispanic, as well as then also the race?
Well, when we're doing our work, we do have very special tick boxes, specific tick boxes, because these people are reporting their own ethnicity.
I
We're
know,
not
it's
reporting it.
self-reporting, right.
So you've got to have things like, well, you guys call Chinese people Asian, we call Indian people Asian. So we've got to put Indian, Asian, Black West African, Black East African, Black West Indies. So we've got to do that. We don't have the issue with Hispanic in Europe, really.
Right.
So, and someone was asking me today about Hispanic ECGs, athlete ECGs, and I had to say I don't know, because I don't know. Only the Americans can answer that, I think.
Absolutely. And when we look at Phoenix, and I was in San Diego and doing the research there, we can see, therefore, that we have the strong presence of the ethnicity of Hispanic and non-Hispanic. And we all know it's self-reported. But I just didn't know what your thoughts were, but thank you.
Thank you.
Hello, Sean Cupp from Cleveland. I'm with Case Western Reserve University and University Hospitals, Cleveland Medical Center. I take care of, within our system at Northeast Ohio, have about 40 high schools, my outreach program, an additional 8 to 10 youth programs with anywhere from a couple hundred to 20,000 kids in each one of those programs. I've been given the task to determine of screening the youth athlete with ECG in addition to the regular H&P. So I wish Kim was here. I'd like her input too. Maybe I'll get it from her later. But what I'd like to know from you guys, your recommendations on using the EKG or ECG for screening. I think I know John's from his talk that he gave that it would be a valuable tool. But do I use the screening criteria that we're using at the NCAA? Do we extrapolate down? Do I pick out the African-American athlete who plays basketball, football, soccer, only screen them and exclude the white females, the white males? What is my exclusion criteria? What is my age? Do I go down to 14 and stop? Do I go down to 12? I'll stop there.
Sean,
I think Joseph's probably best
agree.
equipped to do this.
Well, I faced the same dilemma when we were trying to decide do screening, and I realized that there are political issues. And when you look at the practical issue of what it takes to do ECG screening at a school, it was a lot easier to do all of them and not draw any arbitrary lines that would upset someone. So when we go to school, there's a screening going on right now. We make it available to all the students, and we don't make any distinction. And the interesting thing is when we look at the deaths in our community, a number of them, probably a third, would not fulfill criteria for an athlete. Drill team, dancer, cheerleader. And so, you draw those lines arbitrarily, and I think it's just more difficult. When you look at the cost of it, these are high fixed cost issues of taking people, going with EKG machines, and if you do 1,000 EKGs or 600 EKGs at a school, the cost is really pretty much the same. So we just make it available for everyone, and I avoid that whole dilemma.
Sean, I think you highlight a lot of challenging issues that we face in choosing who do we screen if we're going to use this tool. And I think it is largely dependent on your resources as well as who you think is sort of at highest risk. When we've talked to schools, whether or not it's individual provider taking care of a high school or team physicians at the college level, sometimes it's easiest to start small and then get bigger from there to gain experience. So if it's just you and a cardiologist, you may choose to only screen some of what you consider the highest risk groups as you get started. But then as you get more experience and realize that you want to offer this perhaps across the board to other athletes, gain more resources or other individuals that you collaborate with, you can offer more of a screen. So here in Seattle, we work closely with the Nick of Time Foundation. We had a screen yesterday that was at Ballard High School, where we have a very experienced infrastructure of physicians from sports medicine to cardiology, where we feel comfortable screening anyone. They don't have to be an athlete. We're going to come in and we're going to screen you. And that's because our resources and our experience and our group doing it feels like we can, and we can do it with quality. And so I think some of the answers to your question are tied to your cardiology resources for you as a sports medicine physician. And also it may start in one place and then grow to something else over time. So.
Well, my resources, my pediatric cardiology resource is the section chair for cardiology for the AAP. So there is some political repercussions with his involvement from that standpoint also.
Yeah.
And you were going to comment.
Well, I think in terms of applying the criteria to non-athletes, I used to be worried about that, but I have no concerns really anymore. I think it's a much more useful tool to remain consistent and not worry if it's an athlete or non-athlete because of the conversation about what is an athlete. And I know Sue's not going to be happy with the fact that he just said that cheerleaders are not athletes, and she's in the back there. But
I did not say that. Go on record.
I'm supporting you, but point being, I think it's reasonable to apply those same criteria to non-athletes and to open it up to whoever's available. And the political repercussions are huge, not just, is it why athletes? Why not non-athletes? Well, if you're going to go with athletes, well, why that group of athletes and not this group of athletes? And then it gets into the season, which is even more difficult. Are they actually in season or out of season? So there's all sorts of challenges that have to be overcome, but in terms of I would apply it broadly.
And
How low would
are
you
they-
go in age? Would you go down to 12?
Middle school is tough. I think starting with freshmen in high school would be
So
a reasonable
14?
place. Correct.
We start at age 14 in high school, just for the practical, that's where most of the kids are. But a lot of the kids that we see that have abnormal EKGs aren't athletes at the school, but they're doing recreational things. I saw a girl yesterday who was a black belt in karate, and she's not involved in any school sports, and she has WPW, and she had symptoms that she wasn't aware of. So you'll miss kids if our goal is to try and identify as many kids as possible. If you miss them, if you just narrowly define it as who the athletes are at the school. But John's absolutely right. It depends on. It's sometimes easier to start off with small bites and move forward. So.
Final question.
Hi, my name's Fran Munkenbeck, and I'm from Oregon, and I see athletes, college athletes, competitive that have the inferior lateral T-wave inversion, and we do the workup, including an MRI, and I actually send the MRI up to OHSU where they're pretty experienced, and they say it's negative when there might have been a question, and so I say I need to see them back in a year. We release them, but we have limited budget. It's not like a professional budget, so if I see the kid back, EKG's no different, trying to get another MRI is not easy. I mean, what do you recommend?
Okay, and you make a good point. I mean, the important thing, of course, is that you recommend follow-up in someone with infralateral T-wave inversion. And clearly, an MRI scan is very expensive. And I would say that certainly looking at high-level Premier League soccer players, clearly not all soccer clubs are as financially well endowed as each other. We normally say 2 yearly MRI scans for this group, simply because MRI is better than echo at picking up subtle cardiomyopathies.
So if I don't see, usually like at University of Oregon, they'll say try to get the insurance to pay. If not, we'll pay, but they have a limited budget. And I just don't know if I can just say, get another MRI to be sure.
I guess we do have the advantage of a state-sponsored health system in that, you refer to a cardiologist, that athlete becomes a patient suddenly. He's no longer an athlete, and he gets treated just like anybody else who we were worried about.
Okay.
One other way to also address this, obviously at the follow-up you have a clinical eval, are there new symptoms, et cetera. You look at the ECG, and in some instances you get an echocardiogram, and if your initial echo and your MRI line up, you have a good interpreter, you feel like it was a high-quality echo, you feel like the measurements on echo match the MRI, the ECG is exactly the same, not deeper T-wave inversion, et cetera. you know, yes, no doubt MRI is more accurate and better, but if you have limited resources, there is an argument. I have unchanged clinical circumstance, unchanged ECG. I have an initial echo that lines up with the MRI. I'm going to repeat the echo, and if it's high quality, stop there. At what point do you repeat that MRI? I'm not sure, but
Okay.
anyway,
All
it's
right.
another
Thank you.
option.
Okay,
so.
thank you.
So I know we're running behind. We're gonna take our break. We need it. We'll take our 20 minutes. We'll chew out of our lunch a little bit, and then we'll reconvene. So thank you very much.